Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
This program is presented by Medscape Education Global.
Hello, I'm Josep Llibres, Senior Consultant at the Infectious Disease Division of the University Hospital Germans Trias in Barcelona, Spain. Welcome to this program titled The Hidden Battle, Understanding Chronic Inflammation in Aging People with HIV and Comorbidities. Joining me today are Antonella Castagna, Professor of Infectious Disease at the Vita Salute University San Raffaele Scientific Institute in Milano, Italy. Hello, Antonella.
Hello, everyone.
And we are very lucky to have a geriatrician. We have Howell Thomas Jones, who is a consultant geriatrician at the UCL Institute for Global Health in London, UK. Hi, Howell.
Hello.
Welcome both. In this program, we will discuss how aging, comorbidities, and chronic inflammation intersect in people with HIV, and how to integrate patient-centered care to support healthy aging in people with HIV. People with HIV are aging, and that's good. The median age of people with HIV in developed countries is around 52, 53 years of age. And people with HIV have an advanced age advancement. If we calculate the biological age with a validated algorithm of biomarkers minus the chronological age, people with HIV have a significantly greater age advancement than people without HIV. But lifestyle comparable HIV negative individuals also have more age advancement than blood donors. So that suggests that lifestyle issues also influence the life expectancy in people with HIV. Inflammation is a natural response of our body's immune system to an illness, injury, or something that doesn't belong in our body. And it's easy to monitor in stored plasma samples. We use biomarkers, and the most relevant biomarkers are interleukin-6, soluble CD14, high sensitivity C-reactive protein, and D-dimer. And every one of them have been associated with mortality and morbidity developments. These biomarkers are so sensitive and powerful that a single assessment of one of these biomarkers of inflammation predicts the 30-year incidence of the first major cardiovascular event. In a study in U.S. healthy women, during a 30-year period, a simple biomarker, which was high sensitivity C-reactive protein, was significantly associated with median age and with the incidence of hypertension, diabetes, and smoking. And it predicted the 30-year incidence of cardiovascular events better than LDL cholesterol or lipoprotein A. What are the factors associated with inflammation and comorbidities in people with HIV? In people with HIV, the most important driver of inflammation and immune activation is unsuppressed HIV viremia. So the most powerful anti-inflammatory treatment we have in people with HIV is antiretroviral treatment, so getting a suppressed plasma HIV viremia. Regarding the classics of immune activation and inflammation, we know that even in people with suppressed HIV viremia, a low degree of inflammation persists. It's chronically associated with probably the development of comorbidities. So people with unsuppressed viremia have the higher degree of inflammation. People with suppressed viremia have a lower degree, but it's still significantly higher than HIV negative controls. This is because people with HIV have increased rates of many comorbidities. All of them have been associated, each one, with increased inflammation and, when assessed, immune activation. And only a consistent and robust association of all these biomarkers that monitor the same scenario could have clinical interest. The clinical translation of all this is unknown, and I guess we don't have so far studies that convincingly analyze people with HIV with only HIV. So with good CD4 recovery, maintaining HIV RNA suppression, no lipodystrophy, and no comorbidities. So, Sorella, what about inflammation? Could it also be driving comorbidities in people with HIV?
Very good question. As our patients live longer, healthier lives, thanks to the effective antiretroviral therapy, you said we now must address the new frontier of care. So it means understanding and managing the biological process that accelerate aging and contribute to chronic comorbidities. As you said before, inflammaging. This term describes the persistent low-grade systemic inflammation that characterize aging, even in individuals without HIV. Inflammaging plays a critical role in the development of chronic conditions such as cardiovascular disease, type 2 diabetes, osteoporosis, neurodegenerative disorders, and certain cancers. Now, in the context of the HIV, the story become even more compelling because despite durable viral suppression with modern antiretroviral therapy, people living with HIV show higher level of immune activation and inflammatory biomarkers compared with age-matched HIV negative individuals. And there are several mechanisms are at the play. First, there is a residual viral replication in sanctuary sites. We continue to stimulate the immune system. Second, we have co-infections such as cytomegalovirus, hepatitis B or C, or other latent pathogens that can contribute to the ongoing immune stimulation. Third, microbial translocation from the gut due to a long-term damage of the intestinal mucosa leads to systemic exposure of some bacterial proteins, products like lipopolysaccharides. And finally, there is lifestyle and social determinant of health, such smoking, poverty, limited access to care that can further amplify inflammation. And the consequence of this chronic inflammatory milieu is accelerated immunosenescence, an aging of the immune system that occurs earlier and more intensely in people with HIV. This results not only in reducing immune resilience, but also in tissue damage across multiple organ disease. And clinically, what we observe is striking. Rate of myocardial infarction, stroke, chronic kidney disease, osteoporosis, etc. cancer occur at younger ages and with higher prevalence in people living with HIV. And other perhaps conditions not very well known like depression, neurodegenerative disorder, anemia, sarcopenia. It's important to remind that these comorbidities are not just coincidental. They are directly linked to the inflammatory environment created by HIV. And so I would say that inflammation is not just a background process, it's a driver of morbidity and mortality. And so is that we have to reframe our goals of care. Viral suppression alone is not longer sufficient. We have to reduce chronic inflammation and its downstream effects is the new frontier in improving long-term outcome of our patients.
So, Antonella, could we say that inflammation underpins all these comorbidities and aging and immune senescence are boosting the process?
Absolutely. I think we have to consider HIV infection in another, with other point of view, to managing a chronic HIV infection where inflammation, immune senescence, immune aging are perhaps the more important drivers of the complexity in HIV infection today, that we have true effective antiretroviral therapy to control viral replication, but it's not enough.
So, Howell, what is your experience of comorbidities in older people with HIV?
So I think that we're thinking about aging with HIV. We have to think about how healthcare services can develop to support people aging with HIV so they don't fall between the cracks between many services. And at the moment, there are many services across the UK, Europe, and the US that aim to do this. So my service is called the Sage Clinic at the Royal Free Hospital in London, and we were the first HIV service in the UK, and we have one of the oldest cohorts with over half of our users are over the age of 50, and we have many over the age of 70. So the service existed since 2019 and saw very many people who were frail. And what we identified was the most common things in clinic we were seeing were problems with mood, problems with memory, and falls, which would be in keeping with any aging service. But when we're thinking about HIV specifically, there are common hidden issues which are to do with both aging, but specifically with HIV. These include things like psychosexual issues, in particular in our cohort, erectile dysfunction. But the interesting thing is, what does it mean to age as a minority person in your country? So for us, that could be someone who is a gay or bisexual man, what it means to age as a woman, or particularly, again, in our service, what it means to age as someone of African descent. So when we think about this, we think about 3 ages. We've got our chronological age, the age of which we're born, our functional age, how strong is our body, and then our HIV age, how many years have we been living with HIV? Because it's important to remember that someone who is 70, who was diagnosed in 1990, is going to have had a very different experience living with HIV, particularly when we're thinking about chronic inflammation and long-term viremia, to someone who only acquired HIV a couple of years ago. So then we think about aging. So Antonella already discussed the idea of extenuating and accelerated aging. So what does that mean from a geriatrics perspective? So attenuated aging basically means that at the same age as someone without HIV, we're seeing higher rates of comorbidity. So that could be things like some cancers or cardiovascular disease. But with HIV, it's not just extenuated aging. We also see accelerated aging, meaning that people present earlier with the conditions related to aging. So common things you will have seen already is that it's not uncommon for women with HIV to present earlier with menopause. But again, things like cardiovascular and renal disease present earlier in these people. And all of this really is underpinned by the concept of frailty.
Howell, we are ID physicians. You are a geriatrician. Can you illustrate the definition and how to evaluate frailty in people with HIV in our clinics?
Of course, thank you. So frailty is something as a geriatrician we deal with day to day, but the formal definition is that it's a state of decreased homeostatic reserve, resulting in increased vulnerability to endogenous and exogenous stressors with an increased risk of negative outcomes. So that's quite a wordy definition, but basically what it means is as we get older and we get more frail, we can have stresses both within our body or external. That means that when they push us, we find it difficult to bounce back from those things, whether it be a fall, whether it be a simple chest infection. You don't recover in the same speed as someone who is not frail, and you don't get back to your baseline potentially at all. And now frailty is really, really important in the context of HIV because we can see in many studies now that HIV is directly associated with mortality in people as they age with HIV. And when we think about women in particular, we know that women are more likely to develop frailty if they're living with HIV, and they have a worse quality of life than men living with HIV and frailty. So frailty is a dynamic process. The reason why it's important to diagnose it is because it is dynamic. And we can see from a big study in 2020 that if you identify frailty and you put all of these measures in place to try and support somebody, many people can actually improve and become robust again. And when we think about frailty in the context of the freed phenotype, you think about being robust, moving through this middle ground of being pre-frail and then becoming frail. And what we've seen in these studies is that you can fluctuate between all 3 places. And so that shows that being pre-frail is the best target in a HIV setting to try and prevent the development of frailty. Now, frailty is very topical, and we can see it represented in lots of national guidance, but thinking at a European level in the EACTS guidelines, we do know that diagnosing and screening for frailty has been made a priority. And it's important because when we think of the UN AIDS target, the 495th is proposing that more than 95% of people living with HIV should have good health-related quality of life. And those that we can see that if frailty is directly associated with poor quality of life, is another reason for us to be thinking about it. So how common is frailty, Joseph? So that's one of the things that people always ask me as a geriatrician. So we have a systematic review that came out back in around 2021, presented at the American Geriatric Society, that looked at 26 studies of people living with HIV, roughly 6,500 cases. And what they found, there was a pooled prevalence across all these studies of around 10% for frailty and around 50% for pre-frailty. This means that if you're looking at people over the age of 50, 1 in 10 will be frail, but as high as 1 in 2 will be pre-frail. So this is a large proportion of the people that we're looking after. When we're comparing this to people without HIV, we can see similar rates of frailty, but we see much lower rates of pre-frailty, which again reinforces what I'm saying about the importance of screening and looking at it earlier. But these studies are very heterogeneous. They're done across many different countries with many different ways of diagnosing frailty. Some were very small samples, some only looked at men, and some had mixed cohorts of both seropositive and seronegative people. So really what I would say is that at the moment, we still don't really know what the proportion is across Europe, but I would say probably 1 in 10 for frailty is realistic. Lots of people then ask, well, I don't work in high-income countries. I work in the global south and in middle to low-income countries. Is this really a problem that we see there? Is this something for the future? And the answer is actually no. We already see this in African countries. Frailty is also common amongst people aging with HIVs in those settings. So regardless of where you're working in the world, if you're looking after people with HIV, frailty and aging and chronic inflammation is going to be at the forefront of your clinical care.
Thank you, Howell. So how can we reduce the inflammation or mitigate its effects now? Earlier antiretroviral initiation is the best thing we can do and maintain a good adherence on HIV RNA suppression. Obviously, this is what we can do regarding the HIV disease. We must recommend a moderate exercise, smoking, and alcohol cessation. We must treat all metabolic diseases like hypertension, hypercholesterol, or diabetes, and we must manage the better we can all age-associated comorbidities. Any specific treatment to reduce immune activation and inflammation? We have tried a lot of drugs from a lot of classes, but only 2 have showed important effects on reducing inflammation. The first one are the GLP-1 agonists. They reduce weight, they control diabetes mellitus, but they reduce as well inflammation. And the second one are statins. And we have data from the REPRIEVE study showing, importantly, that the reduction in major atherosclerotic cardiovascular events, the rate of reduction was well beyond what should be expected based only on the LDL cholesterol lowering. So they have an anti-inflammatory effect. Regarding the specific proteins of HIV, there has been a lot of research regarding the soluble GP120. It's inversely correlated with CD4 cell count and CD4-CD8 ratio, and it's associated with increased levels of interleukin 6. And it's correlated positively with the total volume of atherosclerotic plaques. So reducing the levels of soluble GP120 could be an important goal of antiretroviral treatment in patients with increased inflammation. We don't know yet. There's a clinical trial ongoing, the RESTART, and stay tuned to know the results. And let me say something about the socio-demographic determinants of life expectancy. Regarding studies specifically performed in people with HIV, we have studies controlling for HIV factors, comorbidities, and alcohol abuse. And when all this is excluded or controlled in the study, people with HIV have no difference in cumulative survival regarding the people without HIV. And in a similar way, there are many studies showing that we are improving the survival, the life expectancy of people with HIV, which is very close or even the same as people without HIV, but they have a shorter expectancy of comorbidity-free years. And this is important. So we are improving the amount, the survival, the amount of life, but still have a decay in the years without comorbidities. So Antonella, what else can we do to address some of the most important comorbidities in all the people with HIV?
A clear example is cardiovascular disease, I would say, because as you said before, studies consistently show that people living with HIV have a higher risk of coronary artery disease, even after adjusting for traditional risk factors like smoking, hypertension, or dyslipidemia, and chronic immune activation contributes to the endothelial dysfunction, atherosclerosis, and thrombotic events. That means that our approach must be both traditional and innovative. Traditional in the sense that we have to manage blood pressure, cholesterol, diabetes, and lifestyle behaviors, and innovative in that we recognize and target the unique HIV-related driver of cardiovascular risk. And we need a lot of research in this study into drug interaction, to model the possible risk in appropriate way. We still don't have it today. And I will continue to say that managing the disease is only a part of a equation. We must embrace the concept of healthy aging. The WHO define healthy aging not as the absence of the disease, but as the maintenance of functional ability, essentially the capacity of individuals to continue doing what they value through the life. And for people living with HIV, this paradigm is especially relevant. Healthy aging involves physical health, but also social connection, mental well-being, and the preservation of independence. So we have a recommendation at different level. At the community level, we have to be straightforward but powerful to indicate intervention, staying active, even through light activities such as walking or dancing, reduce cardiovascular risk, preserve mobility, and nutrition also matters. High protein, high fiber diet, rich in fruits, vegetable, healthy fats can counteract sarcopenia and metabolic syndrome. Adequate hydration, good oral hygiene, and sufficient sleep are often overlooked but make a real difference. And equally, as Howell said before, it's mental health and social engagement very important. Loneliness and depression are risk factors for decline, while social connection, intellectual stimulation, meaningful activity protect against cognitive impairment and improve quality of life. And also some other intervention like vaccination and preventive care are also critical. I would say vaccination from influenza, zoster, pneumococcal vaccine, and screening, early and aggressive screening for cancers and sensory impairment, such as vision, hearing loss may be important. Finally, I would say that at the clinical level, we need integrated person-centered plans. And the plans should begin when we approach the patient, when we ask the patient what they prioritize in their life. From there, we need to design intervention that combine clinical management of comorbidity with broader strategies, nutritional support, exercise program, medication review, and referrals to geriatric or rehabilitation service when they are needed. And they more frequently needed that now that your age increase. Equally, as a last word, I would say we must not forget palliative care and caregiver support. Aging with HIV can involve complex needs, so ensuring also dignity, rights, and adequate social support. It's a kind of moral obligation for us now.
Absolutely, Antonella, thank you. Howell, what are other important considerations for supporting healthy aging, specifically in older people with HIV?
So I just want to pick up on what, as Antonella said, that what we need to ensure we're delivering is person-centered care. So that's something that we've experienced in our service, and the feedback we've had is very, very good. Often people say that they found just come into a clinic where it's very open and we just talk about healthy aging. We can look at any areas of health that people are worried about. They found it very different to a clinic that's very focused on, say, checking the viral load, checking the renal and liver functioning, then prescribing medications. They felt it was a great opportunity to be seen as a whole person and to really drive their own agenda. So I do think that's important. And so having some form of patient-reported outcome measures in your clinic setting is really important to help ensure that the patient voice is heard. How we do this in geriatrics is using the concept of comprehensive geriatric assessment. So if you imagine a gastroenterologist does an endoscopy, comprehensive geriatric assessment is our specialist skill. And what it is a multi-faceted, holistic assessment that covers many different domains of a person's life. It involves their medical history, their functional history, so looking at how they mobilize and how they cope in their own home, looking at their psychological support, their mood and their cognition, their social setup, who their next of kin is, who's supporting them, are they lonely, what their home environment is like. We think about advanced care planning, what they want for the future. And then other areas are things like their spirituality, what is important to them, and then sexuality, relationship, and intimacy. And what we do is we come up with a problem list with the individual, and we come up with goals, and we set some goals, and then with them we create a personalized care plan and then recommend some interventions. We then arrange follow-up to see how they're getting on with those, and we tailor it over time, because comprehensive geriatric assessment is an iterative process that can be done over multiple appointments with multiple different healthcare professionals. It doesn't just necessarily need to be a doctor. And we've already seen in studies in people living with HIV that comprehensive geriatric assessment has had positive outcomes both on quality of life and length of life. So for those who are not familiar with geriatrics and want to think about how they can do this in their real setting, I would recommend thinking about it in the 5M models of geriatrics. So first of all, we think about the mind, screening for cognitive impairment in your settings, thinking about treating and managing depression and other psychological conditions. Then thinking about mobility, thinking about osteoporosis as you're doing already, but also thinking about falls and preventing falls. I will say, if you want to ask one extra question in clinic as a geriatrician, I would ask your patients over 50, how many times have you fallen in the last 6 months or since I've last seen you? The answer is more than once. That's a sign that frailty could be looming and they need a bit more support and a bit more intervention. And it doesn't really need much to do that. It's just a simple question. The third M is medication. So we know that people living with HIV are disproportionately impacted by things such as polypharmacy and hyperpolypharmacy, as well as things like having a very high acetylcholine burden compared to people without HIV. So ensuring that either if you're not comfortable, you've got pharmacists in your clinic setting who can review someone's entire medication to support you with interventions. Then we think about multi-complexity. That's really multimorbidity, as you both already discussed. And then thinking about in your clinic setting, if you're not managing their diabetes and their high blood pressure and their cardiovascular disease, who is and who can you link in with so we're not duplicating or contraindicating other services that are already in place? And the final thing is matters most. So going back to that person-centered process, what means the most to this individual in front of me? You know, you may say to them, look, reprieve is really important. We want to put you on a statin. We want to do this. We want to do that. But if they say, all I want to do is be able to get out of my house and see other people, I'm so lonely, you're never going to really meet their agenda around your agenda about statins, because you're not meeting them where they want to come. A systematic review that I did identified 6 key areas that could be potential barriers, and it's something that I think is important to think about. So first of all, geriatricians are really worried about their knowledge of HIV. I think over time, particularly in the UK, HIV has been managed by specialists and it's always been compartmentalized away from other forms of healthcare, meaning that other clinicians have allowed themselves to become very de-skilled managing people with HIV. There are concerns about what geriatricians' attitudes could be towards people living with HIV. Are they going to perpetuate HIV stigma? And even if they can support people with HIV, are they going to know about the nuanced things I've discussed already that are specific to aging with HIV, which are different to the wider population? Then we need to think about, geriatricians and their experiences of managing LGBTQ plus people. In many settings that may not be very common as it may be for people who work in the HIV field. And again, people aging with HIV are worried about facing discrimination, homophobia, transphobia in wider aging services. We need to think about those at a larger scale. So what we can do really to meet this need is to screen for frailty in your clinics. How you do this will be really dependent on where you work, which country you work in, and the setting in that where you work. Are you in a university hospital? Are you in a more rural clinic? But just having a way of screening for frailty that works for you and works for your team that you can do over a longer length of time. So EACTS recommends using the pre-frailty phenotype or a frailty index. I would say that the easiest thing to do is to use the pre-frailty phenotype. So that's a scoring system of frailty that has been used in many, many studies across all domains of healthcare, but is very well validated in HIV. And what it does is it looks at 5 domains. It looks at weight loss, exhaustion, physical activity, grip strength, and walking speed to come up with an idea of someone's robust, frail, or pre-frail. But the limitations of this sometimes in a clinic setting is that you have to measure gait speed and grip strength. So at the Royal Free hospital where I work, we made a modified version of this where we asked questions which were subjective. So rather than measuring grip strength initially, we will ask people, are you finding it harder to use things with your hands? Can you open jars that you used to be able to? Or have you noticed that you're walking slow? Or have people commented on that? Because whilst it would be great to do all these measurements, we know that in realistic, busy clinic settings, you can't always do those. For those who are a little bit more up to date with frailty, you may have heard of something called the Clinical Frailty Scale, or the CFS. And this is what we use across the National Health Service in the UK as the recommending screening tool for frailty. Now, this is only validated in the general population of people over the age of 65, which is why we don't use it so commonly in our setting yet, because a lot of our service users are between that 50 and 65 category. However, we are starting to see studies being used in the wider HIV population using the CFS all the way down to 50. We are seeing accelerated aging in this cohort, therefore people presenting earlier with frailty. We can use other things again to screen for frailty. So some people maybe have heard of the Stand Up and Go measure. This is something where a person sits in a chair, they stand up, they walk 3 meters, they turn around and sit down. And you should be able to do that in less than 13 and a half seconds. If you don't, that's a sign of frailty. We use this in our clinic as an electronic version of something called QTUG, which is a digital health platform which can be used to measure more complex ways of walking. So it also looks at your turning, your symmetry, and your transfers, and it produces a number in a small handheld computer that helps to give a predicted frailty score as well as a predicted fall score. And we use that in our nurse-led service to identify people with suspected frailty to refer them on to see me. So there are ways that you could do this. You could go very simple, you could go really complex when you're thinking about frailty. But my main thing is to say is you need to choose something that works for you and your team that you can do continuously over time. It doesn't matter what it is, just having a strategy for frailty. So really, Joseph, you're asking what my take-home messages would be. From my perspective, is frailty is common and presents earlier in people with HIV, and that we should be screening anyone over 50 for frailty at least annually in a HIV service. 1 in 10 people is frail, and 1 in 2 people living with HIV is pre-frail. And HIV services need to be able to do, as Antonella said, is to be meeting not only the HIV needs, but also the aging and healthy aging and multi-morbidity needs of their service users to try and reduce over usage of healthcare services, to save money, and to ensure we support people to live as long and as healthily as possible with a good quality of life.
Thank you, Howell. That's a very nice take-home summary of all this. Antonella, would you like to add anything?
I think that we need to promote holistic strategy for healthy aging so we can help our patient to live longer and to live better. And this approach, I think that multidisciplinary approach is the way. Sometimes we consult the geriatrician when the disease is there, when the patient is frail. Sometimes we call the endocrinologist for managing diabetes. I think that we have to be multidisciplinary earlier, also involving the community, the voice of the patient to understand what are their priorities.
Absolutely. So I hope we succeeded in increasing the knowledge regarding the bidirectional relationship between chronic inflammation and age-related comorbidities, and also factors that exacerbate inflammation and immune activation and comorbid conditions in people with HIV. So hope you gain greater confidence in your ability to integrate patient-centered care to support a healthy aging in people with HIV. So Antonella and Joel, thank you for this great discussion. And thank you for participating in this activity. Please continue on to answer the questions that follow up and complete the evaluation.
This program was presented by Medscape Education Global.